Hi, welcome to the world of cardiology. This is Dr. Jaitly. In this video vignette presentation, briefly I'll be discussing you the basics of how do you treat surgically an aortic stenosis or a valve replacement in a setting of aortic regurgitation also. Now, the indications for AVR or aortic valve replacement are mainly twofold. One is symptomatic and the other is asymptomatic. Now, symptomatic is a given where we know the manifestations of aortic stenosis, like in this setting on the left panel I'm showing you here, is either chest pain, called angina, shortness of breath or dyspnea, and 3 is syncope, exertional syncope, classically that occurs with aortic stenosis. So all these 3 have huge prognosticating factors in the natural history of aortic stenosis, if you will, and they will define the prognosis and therefore the survival pattern. Now, if you were to give an aortic valve, there are 2 choices, a mechanical valve or a bio-prosthetic valve. Now, how do you elicit whether or not which one is good for which patient? Now, we know mechanical valves, they last easily 15 to 20 years these days. Bio-prosthetic valves, they are about to, on a median, they will last about 10 years, 11 years, but they could last up to 15 years if properly looked after, if you will. But bio-prosthetic has a clear advantage. You don't have to anticoagulate these patients unless you have to for other reasons like atrial fibrillation or previous embolic phenomenon, or there's a mitral valve disease existing and therefore there is an atrial fibrillation or an undisclosed left atrial appendage which has possibly a thrombus sitting there waiting to be embolized. So you certainly want to have that as a precautionary measure. Then you're better off doing a mechanical valve or anticoagulate in a setting of bio-prosthetic valve. Likewise, bio-prosthetic valves have an advantage specifically in, just like I mentioned in the mitral valve replacements section in the previous couple of videos ago, that you could place these valves, bio-prosthetic valves, they have a specific indication in a setting where the woman is still in a reproductive stage or age. So like if the woman desires to get pregnant and bear a child, then a bio-prosthetic will be helpful because you don't have to deal with anticoagulation at all, intrapartum or postpartum at all. So that's the clear advantage. And then later on, about 10 years later, 15 years later, as the bio-prosthetic valve wears off or there are signs, then at that point a mechanical valve could be a permanent exchange. It will have to be a redo operation, but obviously that'll require a mechanical. Now, there are 3 different kinds of mechanical valves. One is an age-old Star Edwards, which has been the prototype for a long, long time, where the ball pops in and out through this ring into this cage and allows each time the ball pops up, the valve is open and the ball flops back, the valve is closed. But again, it gives you a little bit of aortic regurgitation and the profile is not the greatest. Again, there's thrombus that can form around these balls, and that's how they wear off, and over a period of time they'll require either anticoagulation. Anticoagulation is definitely necessary, but they will require replacement because of the inherent danger of these embolic phenomena to occur from these thrombi that form around the ball. Now, the other more sort of closer profiles that you will have are bijakshalli, which are tilting disc, like I mentioned in the mitral discussion earlier in the previous video, where there's a tilting disc, but still not the most ideal. Here the tilt is more towards one side than the other side, so the flow occurs, and during the systole and then during diastole the tilt is closed and therefore there is enough, but still some aortic regurgitation can occur here. Whereas here, this is a St. Jude's variety where there's a bileaflet. This is more closer, again, remember aortic valve is a trileaflet. So bileaflet type of St. Jude's can be placed in this position, in the aortic valve position, and that could be as close a profile for flow as one would have in a native valve. Bio-prosthetic valves increasingly are also very prevalent, as I said, the porcine variety and the bovine variety. This one originating from the cow valve, and porcine is originating from the pig valve. So the pig valves and the cow valves, and they're gone by the Carpentier Edwards, named after the authors or the surgeons who actually innovatively designed it. Interestingly, for aortic valve, we have been also using pericardial xenografts and autografts. Now, what are xenografts? Xenografts are from the cadaveric pericardium, and autografts are from the patient's own pericardium, where the parietal layer is removed, and that is constructed to form a valve, and that valve is placed into the aorta, into the aortic root. And it can also take a portion of the aortic root, if you will, with the help of the pericardium, depending upon how good the pericardium at that time of the surgery is discovered too. So it requires a lot of exploration. Again, it's an extended surgery, but pericardium can be removed parietally and be constructed quickly into an autograft. Pulmonary valve autografts, where the pulmonary valve here on the right side in the right ventricle, this pulmonary valve can be removed because again, there's a risk involved. You'll have obviously a pulmonary regurgitation, but that's not as important as the aortic regurgitation that's occurring, or aortic stenosis that's occurring on the left side. So the pulmonary valve could very well be replaced. It's a trileaflet, and that has been autografted here. It's called an autograft, obviously, from within the same body, within the same person. And so it's autografted. It's a human pulmonary valve that's being replaced from pulmonary valve into the aortic position. And that's a pulmonary valve autograft. One quick caveat here is when you have an aortic stenosis, which is with valve area less than 1 square centimeter, obviously that is symptomatic and will require replacement. Aortic stenosis with left heart failure or left ventricular dysfunction will require surgery, because even if the ejection fraction is less than 35%, we know the surgery is going to be high risk, but leaving it alone is even higher risk. So the mortality, it's like the lesser of the evil. You'd rather settle with an aortic stenosis with left heart failure to replace the valve rather than have the valve not done and leave it undone, so this way the risk is even higher. So you don't want to do that. You want to reduce the risk to an extent that even with left heart failure less than 35, even though these patients take longer time to recover out of the surgery, post-operative course could be a little tumultuous, but the fact is that their mortality is much improved compared to the ones who have been left alone. Aortic stenosis with low gradient and low cardiac output, obviously that's an issue which is it's a diagnostic dilemma, and one has to clarify that. So one resorts to a dobutamine stress echo. Now, this is a very, very important test that is conducted and has a very specific indication in the aortic stenosis with low gradient and low cardiac output. Now here, it's very simple. If the aortic valve area increases, no surgery is required, because you know that valve was okay, and it's just that the valve was not opening enough during the resting time, but during dobutamine stress, the valve opened good, and therefore the valve area was increased. So that tells you that. Now, if the aortic valve area remains unchanged, and if the gradient increases, on the contrary, because obviously here the gradient was very low, and if the gradient increases, then the AVR is recommended. So just remember that. And again, for all calcific valves, fibrosis, subvalvular fusions, all of those patients will require valve replacement, including the mitral valve disease. So those are the three kinds of mechanical valves we talked about. We have a specific bio-prosthetic valve, and then of course pericardial and pulmonary valves or xenografts or autografts have been defined also with aortic positions. So it's a very interesting discussion here on aortic stenosis. Hope you found it interesting as well. And we'll discuss more intricacies as we go along. Hope you enjoyed this section. Thank you for your attention. I appreciate it. Bye.